Good morning, everyone. Please come up with your queries. Good morning, everyone. Question number 10. So, first of all, I would like to tell you that Urogyne is literally very difficult. Okay. So, this is the question of ureter injury, right? Question number 10 is about the ureter injury, right? So, there are two questions on the ureter injury. One question is most commonly ureter is injured at. Most commonly ureter is injured at. In which surgery? Okay. Next is high risk chances of the injury to ureter is in which surgery? Ureter injury in which surgery? So these are two questions. Don't confuse between these two. Okay. Okay, don't confuse. The answer to the first question, most common, that was question number 10. Most commonly ureter is injured in which gynae surgery? Okay, we are only talking about here gynae surgery, no other surgeries. Okay, so the answer is abdominal hysterectomy. So the answer is abdominal hysterectomy, right? And when the answer is Verdines hysterectomy, in Verdines hysterectomy, we do radical hysterectomy. Okay, we do radical hysterectomy in the Verdines hysterectomy. There we are, the chances of ureter injury is very high. For example, I will give you example. If I am doing one Verdine hysterectomy every month, okay, then the chances are that okay, you say that I'm doing two Verdines hysterectomy every month. If I'm doing two Verdines hysterectomy every month, then one Verdine hysterectomy ureter will be injured. And if I am doing 100 abdominal hysterectomy every month, then 2 to 3 ureters will get injured. Okay, so that is the answer to the question. Most commonly ureter is injured at. Most commonly ureter is injured in which gynae surgery? So the answer is abdominal hysterectomy, because we quite frequently we do abdominal hysterectomy, right? In my practice, I daily do one hysterectomy. Okay, and whereas Verdines we do once in a month, or rather in 2 months we do one surgery. Okay, I hope it is clear to you. Is it clear to you, Shravan? What is the difference in question number 10 and 18? I think 18 was the same question about Verdines hysterectomy. Is it clear to you, Ayushi? The difference is clear to you? Question number, after your question is question number 34. Yes, question number 34 is, okay, now this was a patient who had vesico-vaginal fistula. Okay, and you are asked to prepare the discharge card of this patient. Okay, and where you how at what time? Now see, the bladder and vagina, a new route has been made between a new here the a new pathway has been constructed, right? A totally reconstruction has been done. So now we want keep that this area should not be under pressure. This area should not be under pressure till it gets healed. So these areas, they are under pressure during pregnancy and during intercourse. Okay. So intercourse is avoided up till 3 months. When vesico-vaginal repair surgery is done, then intercourse is avoided up till 3 months, and conception, pregnancy is delayed for 1 year. Okay, for 1 year. And here I would like to tell you one more thing, that if a pregnancy occurs, it occurs after vesico-vaginal fistula. If it occurs, then only cesarean is done, no labor pains. Okay, only cesarean. Okay, next, Aftab, your question is 13 and 32. So 32 is a 22 years old female present in emergency room with fully outside cervix. If the cervix is outside, then the diagnosis is, write down after, then the diagnosis is, if the cervix is outside the introitus, then the diagnosis is prolapse. Okay, and cystocele is also there. Okay, and cystocele is also there. Can you tell me why this patient land up in emergency? Can you tell me why this patient land up in emergency? Any one of you can write why this patient land up in emergency. 22 years female was having prolapsed uterus and cystocele. Because when such a high prolapse is there at a very less age and cystocele is there, these patients, they get urine obstruction. Their urethra get obstructed. So urine retention. To relieve that urine or stools retention, and they come to emergency. Okay, so we have to solve that problem in emergency. Surgery we will do in a routine OT, right? That is what we say, it is not an emergency, right? So we will do it in the routine the surgery. And what is the conservative or temporary management for these condition? It is pessary. Okay, since cystocele is there, the patient has, yes, since cystocele is there, so the patient must have come with urine retention. So pessary is the conservative and temporary management. And in emergency, we give temporary management itself. Okay. Then next was Aftab 13. So the 13th question is, all of the events during the childbirth which will not cause pelvic organ prolapse. So can you tell me what are the risk factor for prolapse? What are the risk factor for prolapse? All those conditions which stretches the levator ani. Write down, levator ani is the main support. You know na, levator ani is the main support of uterus, right? So all those conditions which will weak the levator ani will increase the prolapse. and all those conditions which will decrease the levator ani stress. Now, when perineal tear happens, the delivery happens very quickly. Yes, yes, is that you're right. Pregnancy, prolonged second stage, all of these conditions, labor pains, they give a lot of stress to levator ani because uterus is supported only by main support is levator ani. Okay, and such a forceful contraction, who is bearing that contractions? Levator ani is bearing that contractions. Okay, okay, so when perineal tear happens, delivery happens very quickly. When instrumental delivery happens, for we apply forceps, we apply vacuum, delivery happens very fast. So anything which fastens the delivery will decrease the chances of prolapse. Is it clear to you, Aftab? 13 and 32? Okay. Next is 41, Rachna. The third degree genital prolapse in early pregnancy is managed by. So, again, I'm telling you that prolapse uterus is not an emergency. Prolapse uterus is not an emergency. Yesterday also I told you कि no need to treat the patient immediately after delivery. Okay, so we have to, in the pregnancy we have to do only emergency surgeries. So and the prolapse in early pregnancy, it is treated by pessary. Now all of you who are present here in the discussion, why not option D? No surgery is no emergency surgeries are done. Sorry, no only emergency surgeries are done. Rachna, is it, have you got? In pregnancy only we do emergency surgeries, much needed surgeries, not any surgery. Is it clear to you, Rachna? So prolapse is not an emergency, it is operated after 6 months of delivery. Okay, okay, so temporary and conservative managements are given, and I will tell you, write down in the chat box what are the 4 conditions where pessaries are given. Number 1 is very old age where surgery cannot be done. Pregnant female, only in early pregnancy we can put in first trimester. Okay, then postpartum 6 months, and at the last emergency, which was the last year FMG question, emergency. Anything else? Any more query? Complication of what is that? You want to tell me? You want to ask me? Complication of what? Complication of what is that? Okay, can you tell me one complication here? It has been asked in FMG exam previously. It is a PYQ. One one condition in which surgery is done at any time. One emergency condition in which surgery is even done in first trimester. There we don't have to see that whether the lady is in first trimester, second trimester or third trimester. What age we use pessary in pregnancy? At any age. Only in the first trimester, not after that. Okay. Yes, Sumit, I am taking your 28th number. Till then you write down one condition in which Surgery is done immediately. We don't see whether it is first trimester, second trimester, or third trimester, or postpartum, whatever phase. There is one condition, medical condition, in which we do the surgery immediately, because if we don't do, the patient will expire. The patient will expire. Usually the surgeries in pregnancy, emergency surgeries, are done in second trimester, like gallbladder operation, like thyroidectomy. All these surgeries which becomes essential are done in second trimester. But there is one surgery, if we don't do that surgery, patient will expire, so we do it in any time. That is appendicectomy. Okay, if the patient has appendicitis, then we do it at any time. This is a no, it is not PPH, it is appendicitis. Okay, PPH can ISAC only be done at third trimester. Let me take the question number 28. Patient of rectovaginal fistula should initially be treated with. So why the patient of rectovaginal fistula should be treated with colostomy? Can anyone tell me? See, when a rectovaginal fistula is there, so if we give a time of 3 months, okay, so that what all injury can occur, it keeps on occurring, and in the last we will heal that, we will do the surgery. Okay, Sumit. So but if we keep this fistula open for 3 months to get all the like we can say, jitna bhi fistula wide hona hai wo ho jaye, how much the fistula wants to get widen, let it wide for 3 months, and in the last we will do the surgery. Okay, because the nearby area is necrosed. So, and if we keep the rectovaginal fistula open, like complete perineal tear, we heal the complete perineal tear also after 3 months, right? But if we keep this open, then stools will get contaminate the whole condition, so we do the colostomy. And after some time, after few months, then we heal the fistula. Is it okay, Sumit? Is it okay, Sumit? Any more any more problem, queries? Any more queries? This is a difficult chapter. Please do ask your queries. Sixth number. Let's go operation. What we do in the let's go operation, we take a mucosal flap and we replace that all the dead skin around, dead mucosa around the fistula. So that is for VVF. This is more something to cramp. Okay, in uretrovaginal fistula and urethrovaginal fistula, moreover we put implants. Have you got it? So in let's go operation, we put mucosal flaps. You just as vesicovaginal fistula is quite often after obstetric procedures, so that is why I have put this name. For VVF, the surgery is let's go operation. Is it clear, Sumit? Is it clear, Sumit? Any more queries? Don't hesitate, do ask the queries. I think the queries are finished. Let's close the session. Thank you for attending. Yes, the fistula class will be in the evening, and we will also do their oncology. Okay, fistula class will be in the evening. The class on fistula will be in the evening. It's a very simple. Fistulas are very simple, and we will be doing oncology also. 4 to 6 there will be the live class on fistulas. So all those who are still want to clear the fistula concept, they can come.